We are going to discuss hypersensitivity and we'll be discussing some concepts of transplant rejection as well as doing some immunosuppressants, right? So, hope so you guys have already done it. It was your homework, but let's have a brief overview of all of these topics, right? Okay. So, first of all, we are going to discuss type 1 hypersensitivity. Can you guys see my screen?
No.
Okay. So, let me share it. Okay.
Yes.
Yes.
Okay. So, can you guys just tell me the pathophysiology of asthma?
Antigen cross-links IgA on mast cells.
Okay, okay. Let's go step by step. First of all, you guys are going to tell me, is it TH1 driven response or TH2 driven response?
TH2.
H2.
Okay, perfect. It's TH2 driven response. So whenever you have TH2 response, you are going to see IL-4 release and it would undergo class switching, right? And then you are going to, okay, B cells are going to be produced. B cells are going to convert into plasma cells. Class switching is going to give you IgE, right?
Yes.
Yes.
Okay, Ig are going to sit on the surface of mast cells. So all of this happens with first exposure, right? Okay,
Yes.
for example, if you have second exposure, what happened? All of these Ig are going to aggregate or they are going to cross link, right? They are going to come closer to one another. So what happens as a result of that? Your mast cells is going to dump its histamine.
And
It's going to
leukotriene.
dump leukotrienes, right? That are
Yes.
basically made of arachidonic acid pathway. If you guys remember arachidonic acid pathway, you have lipooxygenase and cyclooxygenase, which give you prostaglandins and leukotrienes, right?
Yes.
Okay, so this is a classic example of type 1 hypersensitivity. Like you can also see in certain allergen exposure. For example, it can be due to some food, for example peanut, for example shellfish, some medication, sulfur drugs can also give you type 1 hypersensitivity. And it's like insect sting, which like you might have seen a lot of MCQs in your world, it also give you, like it's also an example of type 1 hypersensitivity, right? Because you are going to see degranulation of your mast cells, right? And all
Yes.
of the, you guys know that what happens, histamine is a vasodilator, so you guys will be seeing flushing. You can also see some urticarial rash, right? Okay, so you know what happens in the early phase, TH2 response, IgE, they can sit on the mast cells. Okay, so in, we have already discussed in our cardiology section a drug that also causes mast cell degranulation, guys, and it is highly dependent on the velocity or the speed of infusion, vancomycin, remember?
Vancomycin.
Okay, so what happens in vancomycin if I'm infusing it rapidly?
Non-IgE mediated histamine release.
Okay, perfect. So it's non IgE mediated. So if it's non IgE mediated, can I just like call it as a type 1 hypersensitivity or not?
No.
No.
Yeah, perfect. Whenever you have IgE independent, it's not type 1 hypersensitivity, right? Okay, some opioids can also give you non IgE dependent histamine release or like no type 1 hypersensitivity, but you are going to see degranulation of your mast cells, right? So, okay, and what would be the presentation in case of asthma?
Bronchospasm.
Right. Yes, bronchospasm, anaphylaxis. Histamine is an anaphylactotoxin, right? It
Yes.
vasodilates. Okay. So this was all about type 1 hypersensitivity. So now let's discuss type 2 hypersensitivity. Okay, guys. So can you just tell me what's the main goal of type 2 hypersensitivity? And you guys are also going to tell me some pathologies that like mimics type 1 hypersensitivity and in which you are going to see type 2 hypersensitivity.
The antibodies bind to cell surface antigen that will cause cellular destruction and
Okay,
inflammation.
Perfect. So the idea is that you are going to see direct binding of your immunoglobulins, that is mainly your IgG, right? And in immunology, we have already discussed IgG is a good option in, right? So it is going to tell your complement system to come and destroy this tagged substance. For example, like if you guys remember a disease that is good Pasteur syndrome, what happens in good Pasteur syndrome?
Antibodies against type 4 collagen.
Yes, type 4 collagen. So it means that this antibody is tagging your type 4 collagen and it's tagging type 4 collagen to your complement system to come and destroy it, right?
Yes.
Okay, we
Yes.
have, okay. So what happens in like what's the main idea? You are going to see complement destruction, complement mediated destruction, right? Okay. So we have already discussed some of the components of complement system. Ultimately, you are going to see membrane attack complex, right? That is going to destroy your target cells, which has been tagged by certain antibodies, right?
Yes.
Okay. So for example, we have C3b. You guys know C3b is also a good option in, right?
Yes.
Yes.
Okay. You have C5a. Okay. What's C5a? It's a chemotactin, right?
Metaxis, neutrophils and macrophages.
Chemotaxis of neutrophils. Okay. So it would tell all of the inflammatory cells to come there and destroy your target tissue, which has been already tagged by your some of your antibody. And like we have like a lot of pathologies in which we are going to see type 2. For example, can you guys just tell me some receptor binding pathologies in which the antibodies are binded to receptors? We have already discussed in thymoma,
FC receptor.
myasthenia gravis associated with thymoma. So you are going to see acetylcholine receptor antibodies, right? So that's also an example of type 2 hypersensitivity. If my antibodies are directly coming in contact with something, simply it's your type 2 hypersensitivity. It would call your complement system to come and destroy it. Okay. So this was all about type 2 hypersensitivity. Now let's discuss type 3 hypersensitivity. We are recently done with the pathology SLE, systemic lupus erythematosus. If you guys remember, so can you guys just tell me the main idea of type 3 hypersensitivity? What happens in type 3 hypersensitivity? What's the pathophysiology?
Immune
Immune,
complex mediated
immune.
destruction.
Okay, so first of all, you are going to see immune complexes. So what are your immune complexes? Simply, they are antigen binded to some
Antibody.
antibodies, right?
Yes.
Yes.
Okay, so it's the main goal of your complement to destroy it, right? But in these kind of individuals, you have some complement deficiency. Your complement cannot destroy the initial antigen and antibodies that are formed. So what happens? Their level is going to rise. If their level rise, they are going to deposit in several tissues, right? And when they are deposited in several tissues, you are going to see exaggerated activation of your complement system. It cannot destroy this antigen antibody complex, but it would start destroying your normal tissues and it would give you manifestations of type 3 hypersensitivity, right?
Yes.
Okay, so what happens? Okay, so what will happen to the complement activity if my complement system is consuming more? What happens to the level of C3 and C4?
Hypercomplementing.
Okay,
Decreases.
perfect. So it's going to decrease, right? So C3 and C4 is going to decrease. Okay, similarly, you may be seeing this in polyarthritis nodosa. We have already discussed this condition. Post-strep glomerulonephritis. Whenever you have glomerulonephritis, it's immune complex mediated, SLE. Remember, guys?
Yes.
Okay, so all of these examples are type 3 hypersensitivity. And you know the components of, like for example, if a person is having type 3 hypersensitivity in his different organs, for let's take example of your kidney. So it means you are going to see destruction of your kidney. Why? Because the complement system is activated. So you know okay, you are also going to see edema. Why? Because you guys know that your C3A, C4A, and C5A, C5A along with it is a chemotactic factor, right? But along with that, it's also
Anaphylaxis.
anaphylatoxin. What's anaphylatoxin? It increases the release of histamine. It vasodilates. So if it vasodilates, obviously you're going to see edema as well, right?
Yes.
Okay, so it would increase the vascular permeability, and as a result of that, you are going to see edema. These are some simple things which we have already discussed, right? So, for example, in you world, you are going to see a question that we have a person and he's just bitten by a rattlesnake, right? And we just give him an anti venom, right? Hello.
Yes. Yes.
Okay,
Yes.
anti venom or antitoxin, right? So this can also give you type 3 hypersensitivity. How? Like for example, initial exposure of this anti venom towards these, like let's suppose this poison or toxin that is present in the rattlesnake. Initially, it's going to give you immunity, but with time, as these are also antigens, these are something that come outside from your body. For example, how are these antibodies produced? It's simple. Like just we inject the rattlesnake poison into a horse, right? And horse would just start on producing antibodies against it, right? And we would just take those antibodies, we would just inject it in our body, giving us a passive immunity, right?
Mhm.
Yes.
So still they are antibodies from a foreign organism, that is horse. So sometimes what happens, we can have immune reaction against these antibodies, right? Or these antitoxin or anti venom, right?
Yes.
So they can build up inside our body. Antigen and antibody complexes can build up inside our body, and simply they can give us type 3 hypersensitivity, right? What's type 3 hypersensitivity? They would keep on depositing in various structures, ultimately giving you outcomes. For example, if it deposit in SLE, we have already discussed. For example, if it deposited in your skin, it's going to give you malarish. Okay, it loves to go to your joints as well, giving you arthritis, right? Okay, so this was all about type 3 hypersensitivity.
Okay, guys, I want to do neuroanatomy and neurology with you guys. Just I did the immunology. Are you guys comfortable with that, or you guys can do it by your own?
No, we need your help.
Okay, so I'll just do that with you. Okay. Okay.
Okay.
So it will start. Okay, let's discuss type 3 hypersensitivity. So what? Okay, type 4 hypersensitivity. So you guys are going to tell me what's the basic idea of type 4 hypersensitivity. We have already discussed this in really detail. Like it's a simple kind of hypersensitivity. For example, if we have some our antigen presenting cells are going to come. They are going to present it on class 2, right?
Yes.
Okay, class 2 is going to go into your CD4 cells, right? Hello.
Yes. Then
Okay,
will
CD4 TH1 response or TH2 response. You can
TH.
have TH1 response. Okay, okay. How the TH1 response is produced? It is going to release an interleukin 12. Okay, interleukin 12 is going to differentiate into TH1. They are going to release interferon gamma. They will just recruit your macrophages, right? And macrophages are going to come and they are going to eat this simply. Okay. Okay. For example, one of the example for that is allergic contact dermatitis. So can you guys just tell me some of the toxic things which can cause type 4 hypersensitivity? Like you might have already done the U world. For example, if a person just visited some jungle inside the woods, so
Poison
Nickel
ivy,
wood
contact
allergy
dermatitis.
okay, perfect. Poison ivy,
and nickel allergy.
okay, and nickel. Okay, so what can it do? Simply, for example, if it come in contact with your skin, first of all, some of the poison can go into your cells, right?
Yes.
Okay, and it can be presented like it can go intracellular to your cell as well. It can be presented on MHC1 as well, right? If it is
Yes.
presented on MHC1, so which kind of cells are going to come in play? MHC1.
Cytotoxic cells.
Okay, perfect. Cytotoxic CD8 positive. Okay, and then you are going to see this phenomena as well. Antigen presenting cells are going to come. They are going to present it on class 2, CD4, and you are going to see macrophages. Okay, so it means you already have activated T cells or a kind of memory towards these things simply. So once you are re-exposed, so you are going to see like a kind of inflammation at that site, like the site of exposure simply. So it is your type 4 hypersensitivity, right? So you are going to see CD8 cytotoxicity as well, which is related to your MHC1. And what are the examples of that? For example, we perform a test that is tuberculin scan test, or also PPD test, right? We have already done the PPD test. Hello.
Yes, yes, doctor.
Okay, so what happens in PPD test, guys, please? It's for TB, guys, right?
Yes.
Okay, TB involves granuloma, right?
Yes.
Granuloma are your
Yes.
macrophages, right?
Yes.
Hello? Okay, it's a Th1 response, right?
Yes.
So it means, for example, if a person is having TB and he is in his latent phase, it means still he in his body he have Th1 cells which recognizes your TB. For example, if I take a purified component of this bug and I inject it in a person's skin, so it means you already have Th1 cells if he had some latent TB even, right? Or he just, are you guys getting me?
Yes, yes.
Okay, so he already have Th1 cells. If I am injecting some of the components of that TB bug simply beneath his skin, so these cells are going to come, they are going to release their macrophages and you are going to see some local inflammation. And simply this is example of your type 4 hypersensitivity.
Okay.
Okay, so this was all about type 4 hypersensitivity. Now let's discuss transplant rejection. I'll be just really quick with that. Okay, transplant rejections. Okay. So first of all, let's discuss some terms. For example, if we have a person, right? He had a heart attack. I'm just taking his saphenous vein and inserting into his heart. It means that both the donor, okay, what is donor and what is recipient? Guys, tell me please.
Donor is someone who is donating something, like
Okay, who is
giving,
donating and
and
he is
recipient is
receiving.
receiving.
Okay. So for example, if a person is having, let's suppose, some heart attack and I just take his saphenous vein and insert it back into his heart. So it means both the donor and recipient are same, right?
Yes.
Okay, so donor is basically giving a graft, right,
Yes.
to recipient. Okay, so
Host.
it would be an example of autologous transplant. That is, donor simply donate it to itself. Are you guys getting it?
Okay. Yes.
Okay, so for example, we have a donor and we have a recipient that aren't genetically identical. The most common form of transplant which we usually see that aren't genetically identical. Okay, all of their genome is changed from one another. So for example, if this donor is giving a graft to this kind of individual who is of same species but he is genetically non-identical, so it would be an example of allogenic, right?
Yes.
Allogenic graft. Okay, so we are mostly going to deal with allogenic graft, right, here in this discussion, because like if they aren't genetically identical, so they can have increased chances of rejection, would be our next topic. So for example, if we have a let's suppose that is um, monozygotic twins, okay, and they are genetically identical. Okay, like we have a donor and we have a recipient. They are just twins. Like they are made from they are monozygotic twins. It means they are genetically identical. If he is giving, let's suppose, kidney or graft, so it would be an example of isotransplantation.
Yes.
Okay, so like it's a simple thing. For example, if I am taking a graft and again I'm inserting in myself, it means the genome is same. There isn't any difference with my HLAs. You guys know what are HLAs? What are HLAs, guys? Hello. Okay, human leukocyte antigen, that they are basically groups which give, like, which contribute in formation of MHCs, right?
Yes.
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 MHC1 and MHC2. Simply you can think of HLA, just make your MHC1, MHC2, right?
Mm-hmm.
Hello. Okay.
Yes. Yes.
Okay.
So if I'm just taking my own graft, I'm inserting in my own body, it means all of things are same. Even my blood group is same. So I won't be having some ABO incompatibility. Okay, HLAs are same. So there won't be any transplant rejection, right? Okay. If I am giving a graft in an in a twin that is genetically identical, still he won't be having any rejection because all of his genes genetics are same, all of his HLAs are same. But if I'm dealing with allogeneic graft, that is I'm giving it to a non-identical, genetically non-identical individual, it means there could be some difference in blood. Okay, so we can see some ABO incompatibility, right? We can also see some HLAs mismatch, right?
Yes.
Yes.
If we are having, okay, so it means if I am giving him graft, so this graft can just act as an antigen, right? Or a foreign substance, and it can simply kill it. The recipient would try to kill it. So you are going to see rejection of this graft. The recipient going to reject it, like I won't take it, right?
Yes.
Okay. So okay, do you guys know what is xenograft, by the way?
From another species.
Okay, perfect. For example, if I take a graft from another species, so it would be an example of xenograft, right? So HLA gene cluster code for MHC. Now let's discuss the first rejection, that is hyperacute. Hyperacute. So what is hyperacute rejection? As the name indicates, it is acute, but it is hyperacute. It means you are going to see this rejection
In
inside
minute.
the OR. Okay, inside the emergency, you are going to see it. You are going to see within minutes. You are going to see this rejection. And how would this rejection indicate? For example, if I am giving kidney, and there happens some hyper acute transplant rejection, it means, okay, once I install this kidney, directly you are going to see necrosis, you are going to see thrombosis of this renal artery, and this kidney would just start being destroying. So hyperacute, it all depends on the time span, right?
Mm-hmm.
Okay, so what happens in hyperacute, you guys must remember, there would be RBCs ABO incompatibility. Like for example, if I didn't screen a patient, for example, it's simple that for example, if I have a donor of blood group A and I have a recipient of blood group B, it means A have anti B and B have anti A, right? Antibodies,
Yes.
and they are preformed. Like we won't just undergo the whole process of B cells coming with T cells, the class switching, because they are preformed. They don't need that, right? So for example, if I am just taking kidney from A, so the kidney would have some amount of blood, right?
Yes, that will lead to
Okay.
edema.
Yes.
Okay, along with that, if they aren't genetically identical, then they may be having some HLAs incompatibility or mismatching as well, right?
Yes.
If I am just giving it to this individual, the recipient, so what happens? All these already formed antibodies are going to go. They will be start destroying your kidneys within minutes, right? And it is the example of hyperacute rejection. So the main etiologies which you guys must remember is that RBC ABO incompatibility and HLA incompatibility. And for example, if these antibodies are directly going and they are sitting on the surface of these, let's suppose, red blood cells, the HLAs, and they are directing the complement system to please come and destroy it. So this is example of, you guys are going to tell me already done. Type,
Phospholipid syndrome.
it's type, which type?
4.
Okay, preformed antibodies
No, no.
tagging it for
Type
the complement
2.
system to come and destroy it. It's type 2, guys.
Type 2. Yes.
Okay, so it would be an immediate, you're going to see immediate edema formation. You know why the edema is formed, the complement is going to come, the the C3A, C2A act as anaphylotoxins, right? They're going to release histamines, and you're going to see what? Edema. So it would be within minutes. Okay, what's the management? Management is simple. For example, you should screen a patient before transplantation. You should screen their blood group. You should screen for the HLA matching, right?
Mm-hmm.
Okay. So, and you are going to see necrosis. Okay, so this was all about hyperacute rejection. Dr. Renu, are you getting it? Hello?
Yes, Dr. Ahmed.
Okay. So now let's discuss acute rejection. So like from tomorrow, we are going to do, okay, let me just write it down with myself. So from tomorrow, we are going to do the right? We'll be discussing the microbiology pictures. Okay. So now let's discuss acute rejection. In acute rejection, what happens? Okay. So as I have already told you that it depends on the time span. You are going to see rejection, but it would take some weeks and months. Whenever you see weeks and months, you should go for acute rejection. So in acute rejection, what's the etiology? Your HLA do not match simply. If your HLA aren't matching, okay, for example, so if HLA aren't matching, what happens? Your antigen presenting cells are going to come, right? Antigen presenting cells are going to what? Just tell me, guys. I think
MHC
it's been 2000 times that we are discussing this process. MHC what?
2.
Okay. MHC2. Then what happens? Hello? Guys, please participate, guys. CD4.
That will stimulate CD4, yes, and CD8.
Okay. TH1 response and TH2 response, right? Okay. So it can either activate your TH1 or either it can activate your TH2 response. For example, if it had activated your TH1 response, so you are going to see macrophages, right? Hello?
Yes.
Macrophages would come, they would just destroy your kidney, for example. If this is your kidney and we have some HLA mismatching. Hello?
Yes,
Guys,
doctor,
please
yes.
respond. Okay. So you are going to see destruction of this kidney HLA via macrophages. So it is an example of which hypersensitivity, guys?
Type 4.
Okay, perfect. It's type 4 hypersensitivity. What if these antigen presenting cells just give you TH2 response? They produce antibodies from B cells, IgG tagged in, and complement system come. So what would be the example? What's the example? What's the hypersensitivity? Which example?
2.
Okay, type 2. So what you guys should remember and what's high yield is that you can only have one of them. Either you can have type 4 or either you can have type 2 hypersensitivity in case of acute rejection. And as you guys know, I'm activating my cells, so it would take some time. That is from, like, I do not have preformed antibodies in this case. I am forming the antibodies. So it would take some time. If it's taking time between weeks and months, so basically I call it as acute rejection, right? So high yield point, it can never be both. It can never be both. It can be either type TH1 driven or TH2 driven, or in other words, it can either be type 4 or either be type 2, right? So this is very high yield for acute rejection. So you are going to see edema again. All of the presentation for rejections are same. Edema. You are going to see thrombosis. Okay. Okay, the histopathology. Okay, for example, if it's type 2, it means your complement system is coming here and destroying, right?
Mm-hmm.
Okay, I have certain markers for complement system as well. Okay, I just forgot the markers. What are the markers for complement systems?
C50.
I think CD something. CD4 something. Guys, please just tell me that.
CD20.
Okay, just forgot. Get it. Markers. So okay,
CH50.
CH50 is for checking your complement system. I am telling the markers of these cells. Okay, so just okay, CH50 is just a test for in which we are going
Factor
to
B
see
and
the level
factor
of.
D.
Okay, it's a factor. Okay, I just forgot it. You guys can search. I'll just send it in group. Don't worry. But let me give you the main concept. For example, in the histopathological slide, if in the questions they are telling you that we have some complement markers, or which we have used some dyes which indicates your complement activity, so you guys should think of it is a hypersensitivity. Okay, sorry, it's a acute transplant rejection that is driven by your type 2 hypersensitivity, right?
Mm-hmm.
Okay, so what happens? You know, you're going to see vasculitis, you're going to see rejection, thrombosis, and all of those things. What's the management? Simply immunosuppress them, or just give check for the HLA matching, right? Okay, so then you have chronic rejection. Chronic rejection is very simple. Okay, let me just write it down here. In chronic rejection is same as that of acute rejection. But what's the difference? Again, the time span. You are going to see it within months to year, right? And other
Yes.
things, you are going to see both of these phenomena occurring at same time. So it's a kind of mixed. Are you guys getting it? In Are you guys getting it?
Yes.
Okay, in case of acute, you may either be having type 4 or type 2. In chronic, just first of all, go for the time span. It's for months to year. And secondly, you are going to see both type 2 and type 4 occurring at same time. Right?
Yes.
Okay. So that was all about graft versus host rejection. On the histopathology, you will be seeing rejection of the graft. For example, if you have given this kind of individual a kidney, it means his creatinine is going to rise. You are going to see thrombosis, interstitial fibrosis. It is a chronic one. So in chronic, always involve fibrosis, right? Hello.
Yes.
Okay. Fibrosis due to TGF beta, if you guys remember.
Yes.
Okay. And
And
what would be the management? Simply give them immunosuppression or remove the graft, right? Okay. So any questions?
no, I want to add that we can give him peridone that inhibit TGF beta.
Okay. Yes, we can give them. What's the name of that drug? Peridone, right?
Yes.
Okay, in order to inhibit TGF beta. Okay, so Dr. Obada, you are going to give us overview of all of the transplant rejections, and after that, Dr. El Future is going to give us, and Dr. Gino in the end. Three review. I need 3 time of revision
Okay.
of this rejection, along with hypersensitivity. Start from type 1 hypersensitivity. So this is basically you boot camp going along with these lectures. Okay,
I,
Dr. Obada. First of all, in type 1 hypersensitivity, can you tell me you are going to see which cells involvement?
IgE,
Okay, is it Th1 is okay, Ig or mast cells? Mast cells. Okay, it is Th1 or Th2 driven?
TH1.
Okay, Th1 driven. So where the Ig come from if it's Th1 driven? Macrophages just bring the Ig.
No, in TH1 helper cells, it will activate CD4. CD4
Okay.
will activated by interleukin 12 that will
Okay.
activate formation of B cells.
Okay,
Uh,
so Th1, how do Th12 basically activate your macrophages? Your B cells are activated, but your Th2 response, interleukin 4.
yes,
Okay, I think you haven't just listened here. So in Th1, basically you have hypersensitivity. Th2 response are going to bring your B cells. Th1 is going to bring your
macro.
macrophages. That is
Yes,
granuloma formation. So if you want IgE, it means you need Th2 response, right?
yes.
Okay, so now tell me, it is Th1 response or Th2?
TH2.
Okay, so what happens in then?
It will secret. It will activate the CD4 cells, secret interleukins,
Okay,
interleukin 4, that will activate the growth of B cells,
okay,
and that will activate mast cells.
okay. That would produce IgE. You are going to see class switching. IgE is going to come on the surface of mast cells. Once you have re-exposure of the allergen, these IgE are going to come in contact with another. They are going to cross-link, and as a result of that, you are going to see dumping of histamine leukotrienes, right?
Yes.
Okay, so you are going to tell me in that way. Okay, just tell us about type 2 hypersensitivity.
Type 2 hypersensitivity, it's all about direct antigen
Direct,
binding
yes, perfect. Direct setting of your antibodies upon the structures, different structures. Okay, and
that will activate the
your
complement
complement
system
system, perfect. Okay, what
and will
happens in
lead
type?
to cell destruction.
Yes, perfect. Okay, so what about type 3 hypersensitivity?
Type 3 hypersensitivity, it's a immune complex antigen antibody, mostly
Okay,
IgG. It will activate the complement deposition that will attract
okay,
the neutrophils and that will release lysosomal enzymes. So
Okay.
we will have low C3, C4.
Okay. And we'll be
Uh,
having destruction H and everywhere where they are deposited simply. So, okay.
yes.
Post glomerulonephritis, SLE. Okay. So, do you want to revise the schedule as well?
No.
Okay. So, what about type 4 hypersensitivity?
Type 4 hypersensitivity, it's about delay. It's a delayed type. We have
Okay.
two mechanisms. Direct cell
Okay.
cytotoxicity,
Direct, yes. Direct which cells and which receptor?
CD8, and cytotoxic T cells.
Okay, which receptor? MHC1 or 2?
MHC1 that will
Okay, perfect.
secrete macrophages.
Okay, so what happens in type 4 hypersensitivity then? Antigen presenting cells, all of those story, macrophages coming, tuberculin scan test. Hello.
Um,
Okay. Dr. L Futures, please come. Hello. Hello, Dr. L Futures. Hello. Okay, Dr. Renu, can you please? Hello.
okay, the surface of antigen presenting cells, it will be activated. So it's either
Okay.
by MHC1 or MHC2.
Okay,
Uh,
perfect.
that will acti- that MHC2 will activate T helper 2 cells that will
Okay.
activate complement, uh,
Hmm.
and T helper 1 will secrete macrophages that will lead to
Okay.
type 4 hypersensitivity.
So perfect. Dr. Renu, can you please come and just explain transplant rejections? Hello? Hello? Can you guys
Can
hear
I?
me? Hello? Yes, Dr.
Yeah.
Okay, Dr. Maduri.
Yeah.
We, both of you guys are going to do hyperacute by Dr. Renu and next two types by Dr. Maduri.
I think let's Dr. Meduri explain. I'm little sick today, Dr. Ahmed. So
Okay, so no problem. Just take rest. Hope so you understood because I am doing it
yes,
on your. You just
uh,
told me to do these in
yeah,
the
yeah, yeah.
lecture, so that.
Thank you so
Okay.
much for that. No, no, I'm listening. I'm listening.
Okay. So just take rest. Don't worry about that. Dr. Maduri, can you please come and
Yeah.
explain?
And the autograft is the autologous graft is a thing in which the patient himself gives the donor, becomes a donor and recipient.
Okay. Can you just give us
And
an example of that?
saphenous vein graft replaced with coronaries,
Okay. Then.
and then the next one is allograft.
Okay. Then you have allogenic graft.
Yeah, allogenic graft in which the graft is taken from the same species.
Okay. Are they
Like,
genetically identical or not?
no, not genetically identical,
Okay.
like in blood
Perfect.
transfusions um, and liver transplantation, kidney transplantation, etc. All belongs to
Okay.
allogenic graft.
Okay.
And the next one is isograft. Isograft is the graft donor is genetically identical to recipient. They are
Okay.
identical twins.
Okay.
And the
Perfect.
xenograft is the graft which is taken from other species, like in
Okay.
from pig and etc. Like pig valves are taken instead of the heart valves.
Okay. Then
Mm. Then yeah, coming
what's
to
hyperacute?
hyperacute transplant rejection occurs within seconds to minutes. It occurs in the operation theater itself. This is because of preformed antibodies to against ABO or HLA,
Okay. It's an
in
example
which
of which hypersensitivity.
it's a type 2 hypersensitive reaction.
Perfect. So you already have preformed antibodies attacking your graft, right?
Yes, and it's mostly seen as thrombosis in the vessels.
Okay.
And the treatment is to remove the graft because there is more dangerous rejection has been happening.
Okay,
Um,
perfect. Then what about
the
acute rejection?
acute rejection occurs within weeks to months.
Yes.
This is because of antibodies formed against HLA. This is type
Okay.
4 hypersensitivity reaction.
It can be either type 4 or type 2.
Type 4.
Okay, it can either be type 4 or either be type 2. If it activates your TH1,
Okay.
then it's going to be type
Okay.
4. If it's activating TH2, then you are going to see type 2. But it can either be
Okay.
uh, one of them, right? But in
Yes.
case of
Okay.
chronic, you are going to see mixed,
Both.
both type 4 and type 1. Okay,
Okay.
so it
Okay,
was all
doctor.
about today's lecture.